start. So just like we have been doing a quick review of one of the major systems which are required by anesthetists going for any exam. Okay. So we have already covered neuro and peds in addition to our basic initial discussion. So today we will just try to have some basic concepts of the challenges which are there in a pregnant patient overall. And of course, if there is some time, I will try to give some because there are only few surgeries which are there for gynecology with reference to gynecology. So I will just try to cover some of the points. The basic point will be the same like we discussed yesterday, that this pregnant patient, no anesthesia exam will be finished without having a question on the obstetric anesthesia, or you can say pregnant patient, not necessarily obstetric anesthesia. Okay, because a pregnant patient, there are two scenarios. One scenario is the pregnant patient is going for cesarean section, and the other scenario is the pregnant patient is having some other surgery. Okay, so these are two different things. Some of the things will be the same, but basically these two different sort of questions can come. The third category of question will be with reference to labor analgesia. Whenever you are considering to prepare obstetric anesthesia, you should have this thing in your mind. Basic thing will be the just like in pediatric patient, you should be just thinking that you are undergoing, you are anesthetizing a pregnant patient. So what things should be in your mind? Okay, so the same point should be in your mind. There are physiological, pharmacological, and anatomical consideration. Okay, yesterday I forgot to mention this point. So you can divide your management, your concern in three steps. That what is the change? Okay, what is the effect of that change, and how you manage? Okay, like what is the example with this reference is you will correlate. I will tell the basic, the most important thing which we all face is with reference to airway. Okay, so airway will be coupled together with the aspiration. Okay, so these two things are together, almost together. And when you are telling the examiner, you will say that there are changes which are leading the patient to desaturate. So saturation is one problem, and the other problem is gastroparesis. Okay, so these two things, and the third thing is the physical condition of the patient. So physical condition, the breast tissues are enlarged, the airway is edematous. Okay, and you have limited FRC, and you have more oxygen consumption, and you have risk of aspiration as well. So these three things together, that FRC is increased, airway is engorged, breast tissues are enlarged. So all of these things are resulting in difficult mask ventilation, difficult laryngoscopy, difficult intubation, and to put cherry on the cake, aspiration risk. The gastroparesis is there, so aspiration risk is there. So these are the things which are the first thing to tell. So these are the problems. These are the change and effect. So these are, so how to manage. So what you will be doing, first of all, to start with, you will be doing prophylaxis for acid aspiration. In my 17, 18 years, so sorry, 20 years of my career, I never. Can you mute your mic, please? It is very irritating for me. Please, kindly, I request you to mute your mic. Okay. Cover all ops questions quickly, will be thankful. Okay. Okay. So the thing is that acid prophylaxis is one thing. Okay. So acid prophylaxis with reference, there are three things. I'm just telling you, this is important. This you can answer in any of the conditions. There are three ways to tackle this situation. One is to open the door or throw it away fast from the lower side of the stomach. So what is that? That is either metoclopramide or this domperidone. Okay, so this is, or there are few other prokinetic agents. Of course, with reference to pregnant patient, usually we are using metoclopramide because no other medication will have the time. But Just for your understanding, there are two more things you should be knowing is erythrocin. This is also a prokinetic agent, and this cisapride. This is also being used for as a prokinetic agent. So one thing will be that open the door to kick out the acid down. The second step will be to neutralize whatever bad people are there. Just try to get them involved acid with the base. So neutralize with you are putting some this sodium bicarb, non-particulate antacid. But the thing is that I have never used in my 20 years of career. So I don't know who use it. Practically, it's a disastrous thing because it will increase the volume. Yes, I don't know about the data. I'm not 100% sure about the data. What data suggests, but this theoretically also always have to tell in the exam. I will neutralize the acid with the alkali. I will do the prokinetic agent, and the third thing will be either you will be using ranitidine or PPI to decrease the further acid production. So these are the three things, because PPI or ranitidine will have no effect on the already produced acid. So for that, either you need to put some alkali or you need to kick out of the room. So you will kick out of the room with the metoclopramide and domperidone, okay, or erythrocin or things like that, and you will neutralize with bicarb, and you will. So this is one aspect. Now the other aspect, you have to close the door, which will make it go through the gastrointestinal system to the respiratory system. For that, you need to have a cricoid pressure. Okay, so cricoid pressure with 30 Newton, starting from 10 Newton, making it 30 Newton, from the loss of consciousness to the this development, and you will only release when you have confirmed endotracheal tube. Okay, so basic concept is that you will press it. You will press it in a way that cricoid cartilage is blocking the esophagus. Okay, there is one more very controversial thing which people do is the placement of NG. NG will this, because I'm just trying to few more points other than pregnant. So this is like that, but it is because this topic will be covered here and we don't need to discuss it again and again. NG tube placement will need to opening of the lower sphincter, which is a physiological sphincter, and it's not a good idea or not a routine practice to put NG with, unless it is like if there will be only few conditions in which you should deflate the stomach. Okay, otherwise, because NG can only aspirate the fluid, it cannot aspirate the solid particles, and it will finish the tone. So actually it will dispose. Okay, so this is another important point. The third thing, but in my opinion, this is the most important thing, that is making ramp position. Okay, so ramp position is rapid airway management position. So make the patient head up in a way that external auditory meatus become at the level of sternal angle. Okay, so you there is a specific Oxford pillow. You can see, Google the picture of Oxford pillow, you will find it. The same thing will be used in obese patient. Same points which I'm telling you, you can tell in the obesity. Because in obese patients, again, you do the same thing. You elevate the head side in a way. You putting this is an like special pillow. It's called Oxford pillow. It will raise the external auditory meatus at the level of sternal angle. Okay. So another advantage will be the breast tissue will be pushed down, the abdominal viscera will be pushed down, and actually FRC will be improved. Okay, so these are the things which will be helping you in managing the airway. You will be using a slightly smaller size tube, and the most important point which people will be listening is rapid sequence induction or modified rapid sequence induction if you have rock. Okay, I have not done in my last, I don't remember when did I do rapid sequence induction lastly practically, because we all use rock whenever it's situation like that. I never use sucks. This is my personal preference. Practically, you will tell either in our exam, of course, in Pakistan, because rocuronium is not freely available, and it's not safe to use rocuronium without Sugamedex. Okay, so you should have Sugamedex to safely use uh, rocuronium. Okay, so this is another important point. So these are all about airway management. So this thing you have to tell in few seconds, that patient has delayed gastric emptying, patient can have risk of aspiration, airway. So I have tell this thing in detail. The other complications you will deal in the same way, like progesterone leading to increased sensitivity, reduced MAC. So you have to optimize the MAC accordingly. Increase coagulation factors leading to hypercoagulability. So you need to have DVT prophylaxis. Similarly, like overloaded heart, high output cardiac failure can occur. Maximum cardiac output will be after the delivery of the baby. So these are the things which you should know. And again, just like I told yesterday, you should be knowing what is the change, what is the effect, how to manage. When the change starts, I humbly request you to keep mute, please. Okay. So when the change starts and when it finish. Okay. So you should be knowing very well that when the change starts and when it finish. So this is basic thing. You can have a look on the changes, but again, don't cram. Nobody will be asking. There is this is least there is a least chance that they will ask you the chart. You have to convert into clinical importance. That you don't need to tell how much percentage of this is alone. It will be according to the clinical, that what is the effect, what is the change, what is the effect, and then how will you manage. So make all the changes of pregnancy, whether it is cardiovascular system, respiratory system, renal system, liver. Okay. And like there is a physiological anemia, there is like I have give you a hint, I have explained to you how will you convert, and make your answer of 1 minute maximum, maximum 30 seconds to 1 minute answer of these changes. Like just like you have to make a very condensed like points, condensed point, you can make it at yourself, that how you will answer, because no, you will not find it written in any book. You have to make it according to your intelligence, how to answer this question. And that will be the best answer, that will be the best answer which you make yourself. Okay. Just a second, let me see. Yes. So this is an important thing. Whatever scenario is there, the same things you have to tell. So this is point number one. Then the famous answer, there are two lives. Okay. So you have to take care of two lives. Any medication which you are giving can pass, whatever medication can pass through the placental barrier will have effect. Okay. So there will be two scenarios in which you are dealing a pregnant patient for any surgery. So the more important thing will be that the teratogenic effect of the medications. This is important thing, or anything which can cause fetal distress. Okay. So in the early pregnancy, it will be the abortion, and in the late pregnancy, it is the preterm labor. So you should be clear about this concept, that in early the patient can abort, and in the later half of the pregnancy, preterm labor can initiate. So in any case, whenever you are doing any case, you will the common answers will be, I will inform the patient, I will get involved the gyne ops, and we about the possible outcomes, like any surgery. If they are asking the surgery which they can ask in in the pregnancy: appendectomy, neurosurgery, trauma. Okay. Then some obstetric surgery like SK stitch or McDonald stitch for the cervical incompetence. Okay. Usually, otherwise, any emergency surgery can occur in pregnant patient. There is another important point I will tell you later in few seconds. So if you are handling a patient, pregnant patient for a surgery, you should be thinking about these things. And abortion can occur preterm. So the gyne, and practically, if setup is allowing, they attach the CTG, and there is constant monitoring via LHV. Sorry, not LH, this who will be monitoring the CTG, the nurse who will be monitoring the CTG throughout the procedure, if it is possible. Okay. And you will have properly informed and consented the patient and his family, her family, that about the possible outcome. So this is the common thing you will be telling. Okay. Teratogenic drugs, you should be knowing what drugs are safe in pregnancy. There is a big list, almost, and no medication is 100% safe. and not much studies are done for all that. So the drug of choice for rapid sequence induction and is actually this thiopentone, but practically we use all use propofol. Okay, so you should be knowing about the list of pregnancy safety. And another thing with this reference is the fetoplacental circulation effect of all the anesthesia medication on fetoplacental circulation and transfer. The drugs usually transfer with the molecular weight, with the ionization, okay, concentration. So you should be knowing about that concept, about the that how drugs are transferred there. There's a whole topic of fetal placental drug transfer. So you can have a look on there is a very good article on that topic. So you should know some of the details, but practically muscle relaxant don't cross. Okay, lipid soluble medications will be crossed. Like if you are giving opioid just before after induction of the cesarean section, so that opioid can cause respiratory depression. But exceptions will be when you are bound to give muscle this opioids, then you cannot avoid it. So in that scenario, you have to give. Okay, so this is how you will be monitoring. So I'm just trying to build up a concept for you, because any question can come, and the basic thing will be like the question which can come to you: patient is going for appendectomy during pregnancy, so what are the how will you manage? They can ask you obesity in pregnancy. These are the questions which they have asked a number of times. Another question I will tell, which was asked to me in Irish fellowship exam: decay in pregnancy. Okay, so don't worry about it. You know about a pregnant patient, what's there in pregnant patient, and you know about decay. There is no difference. You just have to remember this thing. Any problem in pregnancy, the effect will be 1 plus 1 will not be 2. 1 plus 1 will be more than 2. Okay. It will become more than 2. So this is the only thing. The problems will be exaggerated. So like if you are dealing a patient of decay or pregnant patient, sorry, diabetic type 1 diabetes, which now she's becoming pregnant. The gestational diabetes is something else. I'm talking, this is with reference to a patient who is already diabetic. So this patient will be prone to have decay, because pregnancy, this is diabetes in young age. Insulin dependent diabetes mellitus can lead to decay. Okay, so the basic principle will be the same. That yes, they can ask you what are the additional risk factors which can prone the patient to decay. So this will be the same thing, some chorioamnionitis or things like that. You can just have a look, what are the factors which can lead the pregnant patient to decay. Okay, so you will find 3 4 points about it. Okay, I'm just giving you, again I tell you, I am just trying to give you a concept of what the possible things can be. Okay, obesity in pregnancy, same principle will be there. You have to rule out any problems which are there because of obesity. And if there is OSA, so these problems will be exaggerated while the patient is is pregnant. But the basic principle will be the same. The same thing, you have to see how much is the end organ damage because of obesity. Is there any development of pulmonary hypertension, or patient is having OSA, or the patient is having any other problems like that? Okay, so the number of problems are the same. Difficult airway will be there, DVT risk will be there. Okay, altered drug physiology and drug handling will be there. So you just have to be sure about the changes in obesity, changes in pregnancy, combine them. Okay, similarly, if some points about laparoscopic surgery, because they can ask you about a laparoscopic surgery in pregnant patients. So laparoscopic surgery, the basic principle is that there is no, it's not 100% contraindicated. The risk will be the same. Yes, you will reduce the pressure around 12. You will find a different number in different books, but you can say that you can have a discussion with the surgeon that try to have lower. I have written slower, lower intraabdominal pressure. Okay, and you will consult the patient. You will tell them that the patient can lose the baby. Okay, so rest of the things are the same. Then there is no difference in any laparoscopic appendectomy in any other patient and pregnant patient. You just have to tell in that way that there are physiological changes, pharmacological changes, anatomical changes making anesthesia conduct difficult. And when they are doing laparoscopic surgery, already FRC is reduced, and it will also depend on the how weak pregnant it is. As a rule, elective surgery is not advisable to be done in pregnancy. You have to wait till the end of pregnancy. If there is an emergency surgery, you cannot delay. in between, if you can delay, try the safer period will be the second trimester. Okay. If it is first trimester, try to push the patient to second trimester. Okay. If it is in second trimester, try to put it after the pregnancy. So this is the basic principle. The safer time is the second trimester, but it is not 100% safe. So these are the rule, the things you should be knowing. Okay. So if any point I missed, you can ask me, or if I recall after a few minutes, I will tell you. But I have told you the basic principles, the basic thing, how to handle a pregnant patient. Okay. Then some of the diseases we will try to quick review of PIH and this bleeding disorders, bleeding problems with reference to pregnancy. So first of all, if we have some words about just a second. Pregnancy induced hypertension. I think I have exhausted all the pages. Okay. So, PIA with reference to eclampsia, you should be knowing this, the basic principle that it is usually occurring after, the things will be according to the clinical condition of the patient. You will be labeling according to the blood pressure of the patient, that how much is the blood pressure and how much are the systemic involvement. So either it is simple preeclampsia or it is severe preeclampsia. And there is another important thing, which is help syndrome. Okay. So if the fits occur at any point, it will become eclampsia. Okay. And other points which will be important, like there will be some neurological involvement, there will be some cardiac involvement, there will be some pulmonary involvement in this. There will be according to the different patient will have different picture. Okay. Just a second. So another point which is important with in this condition is there are three basic principles. One number is control of blood pressure. This is goal number one. Number two is control or prevention of fits. Prevention of fits. And the third is delivery of the baby. Okay. Because at any point of time, priority is the mother. Okay. The if you are at any point of time, this is making a threat to the life of the patient, you will go for of course this will not be your decision only, but usually the ICU, anesthesia and obstetric team will decide about the patient situation. They will try to prolong the pregnancy. Okay. They will try to control the blood pressure. They will try to control the fits, like blood pressure they will be using. The question they will ask how to control the blood pressure. So either it is labetalol, either it is hydralazine in emergency cases, like when you are conducting the anesthesia, or the patient must be taking methyl dopaldomat regularly, or even labetalol regularly to control the blood pressure. Okay. So for when the patient is with you, you will be handling with either of these labetalol or hydralazine. Even if it is not available, people are also using nitrates, but this is not the recommended answer in the exam. It's you always try to give labetalol or hydralazine and magnesium. Okay. So the another question which they will be asking you about magnesium, how magnesium works. So it's a membrane stabilizing. It is not only decreasing the blood pressure by causing vasodilatation, okay, by smooth muscle relaxation, it is also preventing the fits. Okay. So this is the role, and they will ask you the drug levels. I don't remember the exact drug levels, but initially there will be decrease in deep tendon reflexes. The second step will be respiratory problems, and the third step will be cardiac problems. So three steps you should be knowing, and very important, there are three different units which are being used. One is mg/dl, one is millimole, okay, and one is milliequivalent. So usually the millimole is the number is the lowest, number two is milliequivalent, and number three is magnesium. So just for example, if it is 1 millimole, it is 2 milliequivalent and it is 4 milligram per DL. That's what I remember. Okay. But usually the levels you should be knowing one unit. Okay. And usually millimole, because it is a SI unit, try to remember in SI unit. But it depends on whatever. So you don't forget that whatever number you are telling in the correct unit. Okay. Because it will create a bad impression. But usually initially there will be deep tendon reflexes, the second will be respiratory, and the third will be cardiac. Okay. And how to monitor the magnesium levels by clinical. Okay. There may be, if the patient is already before, not intraoperatively, because intraoperatively magnesium will lead to delayed muscle activity, sorry, muscle relaxant effect. And this one, practically four things you should never forget. Number one is clinical judgment. Number two is deep tendon reflexes. Okay. Number three is urine output. People sometimes thinks that magnesium decrease urine output. No, it's not like that. Magnesium, if you are giving, and there are chances of renal failure in eclampsia, preeclampsia, because the patient is actually practically volume depleted with severe vasoconstriction. So renal failure can occur, acute kidney injury can occur in these patients. So if you are giving magnesium and the patient suddenly have renal failure, and you are keep on giving magnesium, the patient will be prone to have toxicity. So this is the relationship between magnesium sulfate and urine output. So whenever you are giving magnesium, you have to make sure that urine output is there, because if urine output is decreased, you be aware toxicity can occur. So you have to do the serial blood levels, clinical judgment, deep tendon reflex, ECG, and vital capacity. Like you have to monitor the patient is breathing well, saturation is good, patient is not having CO2 retention. Okay. And any ECG changes, urine output. So this is with reference to magnesium sulfate. The maximum question which they can ask about magnesium sulfate is which I've told you. There are no other questions about it. Okay. So this is all about this. How to handle, they can ask you in state that how will you handle the situation in emergency. So the same protocol will be there. You have to use diazepam, or you have to use thiopantone, or you have to use propofol. Okay. Or you will start with a loading dose of magnesium and then maintenance. So the basic principles are the same. You will prevent the airway, you will prevent the tongue damage, you will prevent any injury. You will, if the patient conscious level is deteriorated, you will try to intubate the patient. Okay. So the basic principle, the same, which you should never forget: airway, call for help, airway, breathing, circulation. Airway, breathing, circulation. I will make sure patient airway is patent. I will make sure patient is breathing well. I will make sure patient cardiovascular system is supported. That's how you should be telling any answer of emergency. And don't forget to tell call for help. Call for help, stop. You stop will be anything stop. Okay. You will stop the surgeon if it is has occurred intraoperatively, like you have given spinal to a patient with pre-eclampsia and now patient has fits. You will immediately inform the surgeon. You will call for help, and the next of the drill will be the same. So try to correlate at this, because when they are asking the question in exam, you don't try to answer without the situation. Okay, without the scenario, because the basic things will be the same, but you have to correlate with the scenario in which they are asking you. So this is some words about it. The rest of the things are the same. Again, you will prepare ICU, you will inform the neonatologist. Patient may be, the baby may be premature, so patient will be going to the baby will be going to an ICU. Okay. And now I will correlate this thing with the next topic, which we'll be discussing quickly, is about the bleeding. Okay. So there are more chances of IUGR, there are more chances of prematurity. So these are the things. So you, when you are telling the examiner about PIH, you will be telling severity, how severe it is, according to the history, examination, and investigation. How severe is the preeclampsia? How is the drug compliance? Whether the blood pressure levels are controlled? Whether there are any symptoms? The what medications is the patient is taking? And the next step will be, they will ask you one more question about it. Choice between GA versus the spinal. Okay, so actually, if there is no no current coagulopathy with reference to PTINR, with reference to platelet count, because in this scenario there may be help can occur, hemolysis, elevated liver enzyme, and low platelet. So this can occur. So if you have any doubt, don't tell about regional. Okay. Otherwise, because there is no safe. Remember one thing: you should be very clear about spinal versus epidural versus GA. Okay. If you ask me, all three have problems. Nothing is safe. The problem with reference to bleeding, spinal is better than epidural because spinal needle will be thin. So if you have any doubt, it is better to have spinal. If you think about hemodynamic instability, epidural alone or epidural with GA for the better control of the hemodynamics, epidural plus GA or epidural alone is better. So you just have to tell that we have to analyze the patient with reference to coagulopathy, with reference to hemodynamics, and then you will decide which you should give. If the patient has any signs of raised ICP, it is better not to give central neuraxial block. Okay. So these are 2, 3 things. If you are giving GA, again, the problems of stress response. So you have to blunt the stress response. In this scenario, you can tell that usually we don't give opioids in pregnant patient. You try to avoid, but in this scenario, you will give whatever opioid you have to blunt the sympathetic response. Or you can say that if remifentanil is there, it can be used without any trouble, because remifentanil will not cause any respiratory depression because it's kicked out of the blood very quickly. Okay, so remifentanil you can use, lidocaine, esmolol, and the control of the blood pressure before you start the surgery. So the problem will be with GA, the problem will be the laryngoscopic stress response at intubation and at recovery. So these 2 points will be important. Spinal, I have told you, there will be sudden drop in blood pressure because these patients are volume depleted. So if you are giving spinal, you can say yes with reference to bleeding and possible risk of epidural hematoma. It is better to use spinal with pencil point needle and a smaller gauge needle, but this can cause. So if you are doing this thing, you have to tell that you have to be ready for hemodynamic instability. You can say that I will take a arterial line, I will preload the patient with the colloids, because if you are giving too much crystalloids, capillaries are already leaky in preeclamptic patient, and patient can easily go in pulmonary edema. Okay, any pregnant patient can go in pulmonary edema because of overloaded state, but in preeclampsia, because there are vascular problem and the patient is more prone to go in overload. So you can just explain to them that nothing is safe. We have to decide according to the risk versus benefit in that specific patient. Spinal has this problem, this benefit, epidural has this patient. If you are giving epidural with GA, it will be having, you can defend it by saying that maybe they are starting with the induction of the pay labor, and this is giving you a good, not necessarily all pre-eclamptic patient go in cesarean section, not 100% necessary. So epidural will be giving a very good labor analgesia, and then it can be proceeded if needed for the surgery, or epidural can be placed even again, it's difficult to defend, but if you can defend, you can tell that if the patient needs to have a blood pressure control, you can place epidural even after the surgery. Yes, it's not a routine practice, but if they want to listen, you can tell. Otherwise, this will be a dangerous point. It is always better to place epidural before GA. Okay, but if the situation is like that, that epidural is needed for postoperative analgesia, okay, so you can tell, again, risk versus benefit. Answer in viva like a diplomat. Answer in the exam like a politician. Don't say closed-ended sentences. Say that always I will outweigh risk versus benefit and I will choose according to the clinical situation. This has this problem. Okay. So now I will go, because we have limited time. So I will tell few words about bleeding. Remember one thing, bleeding, they can ask you in 2, 3 steps. One bleeding is antepartum and postpartum. This is one concept you should be knowing. One is painful versus painless. This is second point. Number three is that bleeding related to pregnancy and bleeding not related to pregnancy. Okay, the patient may have hemophilia or any coagulation problem, and now patient has become pregnant. So they can ask you, this scenario can be asked, that you have a patient with hemophilia A coming for cesarean section. So don't worry about it. Don't panic. You should be knowing what is hemophilia, what are the problems. Okay, so you will be, the same principle will be there, that you have to maintain the APTT, you have to maintain the factor 8 levels. Okay, with, you can give a factor 8 concentrate, or you can give cryoprecipitate, or you can give FFPs according to the scenario. And one more thing, they can ask you in talks. Don't ask me the formula. I'm very bad in calculations, but you should be knowing what is the formula to calculate the factor 8 level, the how much factor 8 levels are required, and how much mils of that product which you have chosen will raise the factory activity. You should be knowing this thing. This is there in any patient. Just like any patient, you have to correct it and maintain it throughout the perioperative period. Even post-operatively, for certain period of time, you have to maintain by giving the products. This is the basic principle. Okay, this is one thing. The painless versus painful, if it is abruption, it is painful. If it is uterine rupture, it is painful. If it is placenta previa, bleeding may be painless. So then you can read about some of the other causes as well. Okay, so vasa previa is one of them. So placenta previa, I should be knowing what types of placenta previa. If it is covering, it is near the os. If it is covering half, it is covering full. This is the types you should be knowing. They can ask you about it. And the dangerous thing will be accreta, increta, percreta. Accreta in the mucous membrane, sorry, in the mucosa, and then in the muscle, and then going through, entering the abdomen and the pelvis. So in that scenario, that will be the most dangerous. If you have like this, they can detect either by ultrasound or by MRI. Okay, so you don't need to go in the details. You say it should be, if it is in elective surgery, now you have to prepare for all the bleeding problems. Okay, so you should be thinking about all the two three things you should be in, because not everything is available in Pakistan, but you have to tell that internationally, if you have a such patient even goes to interventional radiology, and they place a balloon in internal iliac vessel. So in case intraoperatively they need to do tamponade, they can do tamponade, or they can even tamponade before surgery. Okay, because this will reduce the chances of bleeding. This is one option. The other option, all the surgical maneuvers, you will be telling. They will try to do the massage, they will try to do the Balinge, they will try to, there is another which is called as Beckery balloon, which is placed through vagina, and they place it and inflate it. I did never saw it in Pakistan. Yeah, I saw people using it here in Saudi Arabia. They are using this Beckery balloon. You can, I don't know the exact spelling even. Beckery balloon for uterine bleeding. You can write, and so this is an anesthesia factor with reference to bleeding. All the best friends which I told you yesterday, all the homeostatic factors, oxygen, CO2, temperature, okay, and all in all bleeding patient, what will be the problem if you don't control the bleeding, or if you overcorrect it? The problem will be the lethal triad. Okay, the patient can go in lethal triad. So lethal triad is acidosis, hypothermia, and coagulopathy. Okay, so whatever you are doing, if you are giving too much fluid, these problems can occur. So with this reference, in elective surgery or emergency surgery, what will be the difference? In emergency surgery, if suddenly it was undiagnosed and suddenly bleeding start, you will say call for help, activate massive transfusion protocol. So massive transfusion protocol, and get the crash pack. Okay, you will find different names over there, but usually the crash pack, it's a set number of products having PRBCs, platelets, cryoprecipitate, and also other broad products, and even up to Novo 7. Okay. Some people will say Novo 7 is not in crash pack, but it just to recall that in addition to crash pack, you will call for all the disaster management for bleeding. So here, in addition to the because I'm not mentioning the uterotonics. Uterotonics are already there for uterine bleeding. Oxytocin, progesterone, this one, ergot, PGF2 alpha, and misoprostol. These are already there, but extra things is Novo 7. Okay. An extra thing is a Nova 7. So you should be, and another, if they are giving FFP, sometime there may be use of PCC, prothrombin complex concentrate. Okay. Don't tell till the time they ask you. You can just, when you are finished with the common things, if you will start with Nova 7, they can catch you very easily. Okay. So if you have told the basic things, then you can go to this thing. So if emergency suddenly bleeding occur, as I told you, you will try to control. They can do the packing. You can call the uncross match O negative or O positive blood group. Okay. And this is a set hospital protocol. You can read about massive transfusion protocol. So you will activate massive transfusion protocol and crash pack will come, and you will try to give like that. Another important point with reference to, you should be knowing few words about cell saver. Okay. And you should be knowing some words about how to monitor the bleeding patient. So it's 2 3 things maybe use. One is INR, one is ACT. Okay. Then the most important is TAG or thrombolastography. Sorry, rotum. TAG or rotum. Again, remember one thing, because it's not available in frequently in Pakistan, and nobody is using cell saver. But keep this in within yourself. Don't Dr. Pradeep, I will answer your questions because I have limited time. I don't have time to answer. If you have, just write the question. I will try to answer. Just write down in the chat. Okay. So remember that cell saver, about the cell saver, there are 2 3 points. Cell saver will, what you do. There is a only with reference to pregnancy, and that this amniotic fluid should be filtered by special filters in cell saver. This is one thing. Then there are two, actually, usually they are using two different sections. So the clean bleeding they are doing with the cell saver, it is going with one tubing, it is being cleaned, processed, and according to the machine, they can concentrate it up to 50 to 60 to 70%. Mind it, there is no blood products in it, no coagulation factor in it, only PRBCs. It's only giving the hematocrit. Okay. So this is the principle of cell saver. I don't think so. You need to remember two more than this. INR, ACT, and TAG and rotum, they will just dictate you whether the patient need FFP. Okay. If there is a delay like this, and then there is an alpha angle, and then there is maximum amplitude. So maximum amplitude is platelet. If it is down, it is platelets. Alpha angle, it is cryoprecipitate, and this reaction time is FFPs. This is, I just know this basic small thing. And if you want, because this can occur in the talks as well. So my suggestion will be for you will be to prepare this topic, rotum or TAG. Both of them are the same, only there are difference in company. Uh, and if, for example, maximum amplitude is not achieved, this is platelets. Last thing, if everything is good, but the clot is rupturing fast, so it means fibrinolysis. So you need to give tranexamic acid. Okay. So tranexamic acid for fibrinolysis, reaction time, FFP, alpha angle, cryoprecipitate, maximum amplitude, platelets. So these are the things which you should be knowing. And the last is Novo 7, recombinant factor 7. It is involved in the not only in the initiation, but also for amplification and propagation of the cell-based model of coagulation. Okay. So if nothing is working, then you will go for Novo 7. Okay. So and of course they can ask you what are the complications with Novo 7. Thrombosis, because it's a atomic blast of coagulation will start. I have used few times, and actually nothing happens, but you should be knowing the complication which can occur. So bleeding patient, type of the placenta accreta percreta, leading to uterine either ligation or B-lane suture, Bakri balloon, hysterectomy. So in this scenario, if it is an elective case, you will be saying that we need to, as a team, it's not the you who will take the hysterectomy consent, but you should be telling that, you should be knowing that in this case, patient can end up in hysterectomy. Okay. So ICU, NICU, radiology, and logistics. You have to inform the OR staff that you have a very, very important and very delicate case in which massive bleeding can occur. So not only the OR staff, the blood bank, the hematology, and in elective case, if there is pre-operatively there is a baseline correction of hemoglobin, you need to do it. Okay. And in place, usually some of the blood products should be there with you when you start the surgery, because placental uterine bleeding can lead to disaster within minutes. Okay, so at least 3 or 4 units of PRBCs and blood products should be there in the room when you start the case. You can tell, you can make the story like this. Okay, we are short of time. There is hypotension and tachycardia, but I don't understand your question. I have given and he misguided me actually. Pardeep, this is not a relevant question at this time. Okay. I will answer to you. Try to ask this question in the group. I will answer to you. Okay. I have only few minutes left, and I'm trying to tell some of more points about this obstetric anesthesia. Pardon me for that. So we have covered some of the major concerns which are their challenges: physiological, pharmacological, anatomical consideration, bleeding, hypertension. Then very important, I have discussed actually this case so many times. You can I will highly suggest you to have a look on the playlist, a cardiac patient in pregnancy. Okay, so mitral stenosis or mitral regurgitation or aortic stenosis, or patient with peripartum cardiomyopathy. Okay, so peripartum cardiomyopathy is a diagnosis of exclusion patient. You will see the diagnostic criteria that peripartum cardiomyopathy, the patient does not have any cardiac problem before, any valvular disease before, and now in the later half of the pregnancy, patient suddenly develop cardiac failure without any reasons, and having very severe LV dysfunction, and patient is going in pulmonary edema with respiratory distress. They asked me, when I was asked in this exam, even I was so miskeen, I have not even heard about the name of peripartum cardiomyopathy. I was able to think that this is cardiomyopathy, but I even did not know the name of peripartum cardiomyopathy. So that's the history. Whenever I'm telling about peripartum cardiomyopathy, I just remember what I was and what Allah has made me now. So say Alhamdulillah to for Allah can make anyone anything. Allah can bless you. Okay, so cardiac patient, remember few basic things. That again, the comparison between epidural and spinal and GA is the same which I told you for preeclampsia. There is no difference, because these patients with mitral stenosis can be on anticoagulants, warfarin, okay, or they are on heparin infusion, or they are on Claxane. So you have to outweigh risk versus between bleeding and hemodynamic instability. Okay, usually GA will be preferred, especially if it is tight stenosis. You cannot give spinal. Epidural, yes, in certain conditions you can use epidural to reduce the stress response. Okay, and the same principle will be there: heart rate, blood pressure, sinus rhythm, okay, and my best friends, CO2, oxygen, temperature, you have to maintain. Acid base balance, no hypercarbia, no acidosis, no hypoxia, no hypothermia, no acid base imbalance. You have to maintain. One mistake which people do, it's not bradycardia which you want, it's not tachycardia you want in regurgitation, it's not bradycardia you want in stenosis, it's not increase SVR you need, or it's not decrease SVR, it's maintaining. If, for example, if you have a patient with the mitral regurgitation, they say that you maintain the SVR and you don't let it increase, it doesn't mean that you will decrease the SVR, because if SVR will be decreased, the venous return will decrease, and if venous return is decreased, you will not be able to maintain the cardiac output. Similarly, if you have a patient with aortic stenosis and you say that tight, slow and tight, it doesn't mean that you will increase the SVR. It means you will not let it go down and you will try to maintain it. This is the answer. I hope you understand it, because in the books it is written slow and tight and fast and loose. So don't misunderstand this point. You just have to say that it is better to keep it in the lower normal, so 60, around 60 to 70, and here around 80 to 90, because tachycardia is never ever good for the patient. Don't never forget this thing. Similarly, SVR you have to maintain. You have to maintain the sinus rhythm. You have to maintain the SVR and don't let it fall down or go up. Rocuronium. Okay. If it is Sugammadex is available, I will go for modified rapid sequence reduction. Okay. So few points are left. Again, in this scenario, high risk consent, ICU, invasive monitoring, cardiac output monitoring if it is available, okay, arterial line, and rest of the things I have already told. Yes, with reference to oxytocin, okay, you will try to avoid, or you will try to give in slow infusion, not more than 5 units, okay. Try to dilute it and give slowly. Carbitocin, which is available in Saudi Arabia, not available in Pakistan. Carbitocin is a better version of oxytocin. Okay. Okay. So, the other ergot, the problem will be it can cause sudden vasoconstriction, and it can cause hypertension. Okay. So you have to say that whatever uterotonic you are using, you have to use with care, because it can cause serious sequelae. So some of the diseases, we have some few points about labor analgesia. So in the first stage of, whether it is first stage of labor or second stage of labor, they can ask you how to initiate this. This is a question with reference to counseling. What are the pros and cons of epidural? What are those show you should be knowing? What are the incidents of complications? You should be knowing hypotension and PDPH and the serious complication. You should be knowing. There is a chart in the group in my with echo, clinically and echo. Okay. It's not diagnosed postpartum, Pardeep. It's diagnosed with echo, usually. Okay. And diagnosis of,
it's diagnosed postpartum, but in echo, I know it's diagnosed in echo, but when patient is then having some problem and post-op, then we do echo. Is there any test or we symptom we recognize preoperatively?
no, Pardeep. I'm really sorry. I'm not taking your question at this moment, because I don't have the clear answer. And this is I'm telling you, this is clinical diagnosis. Peripartum cardiomyopathy is a clinical diagnosis, and usually you just do the echo. Okay. Okay. So yes, because actually I have to leave, Pardeep. I'm really sorry. I have to rush for prayer. I have only, yes, we can discuss this thing in detail in the group. Okay. But because this is a whole topic, I'm trying to cover which I have done in 20 hours, I'm trying to cover in 1 hour. So unfortunately, I don't have time to answer your question. Okay, so
no issues.
so with reference to labor analgesia, remember one thing, they can ask you with reference to its counseling, how to do the counseling. You have to tell the incidence, the problems incidence rate. Okay. There is a chart, you should be knowing about it. This question will not be asked in table viva. Most probably this question will be asked in talks. This is one important thing. With labor, how to initiate. Usually whenever, whatever you do, the normal thing, I will tell you that it's usually the dose you are giving is 0.1%, with 2 mics per ml of fentanyl. This is the routine epidural infusion we are giving at around 5 to 20 ml per hour. This is the routine for labor analgesia. After giving an initiation with test dose of lidocaine with epinephrine. This is the usual practice. And then they can ask you, do you have a patient? And now the patient is approaching the delivery, and patient is having severe pain. So what are the different options? So you will say that you will evaluate the situation, and there are options. You can give a sitting dose. You can give a this saddle you can give, or they can give some opioid. According to the scenario, you have 2 3 options. Of course, pudendal nerve block is also for the second stage of labor, when the perineal involvement is there. I have never used it, so I have no idea how to give pudendal nerve block, but this is also for the sensory involvement, which is there in the last stage of delivery. Okay, so these are the certain options which should be they. If it is in the initial phase and the patient is receiving a high dose, and analgesia is not there, then you can say that you will slightly withdraw, pull out catheter by half centimeter, and you will readjust, and you will see whether the effect is changed. So these are the common questions they can ask you with reference to labor analgesia. But basic principle, remember that you have to tell the consult the patient, you have to rule out any coagulopathy, and then you will perform the labor epidural. Okay, so unfortunately I have to leave. And any question which is missing, Pardeep, now I don't understand your question, what you were asking. Can you just speak out again? What is your question? I don't understand your question actually. With reference to peripartum cardiomyopathy, can you just speak out quickly? What were you asking? Can you hear me, Pardeep? Okay, I think because I have to rush somewhere, I have to go to pray. So I think I have tried to give you an insight about the common problems, the common things which are required in a pregnant patient. With reference to gynecological surgeries, there are certain cancer surgeries. Okay, vaginal hysterectomy, they can ask you for UV prolapse, cancer surgeries. The basic principle is like any other abdominal surgery or pelvic surgery. Okay, cancer surgery is a separate topic. I will try to discuss. I have discussed before. I will try to discuss it again. Okay, and obstetric anesthesia, because I have done too much details many times, and you can have a look here. Okay, this is the playlist for gyne ops. I will uh, try to share again. And peripartum cardiomyopathy I've discussed in detail. So Pardeep, you can have a look here. I have discussed this topic multiple times. You see decay in pregnancy, labor analgesia. So because it's a special scenario these days, I'm just trying to help out the people who are going for the oral exam. So tomorrow I will tell you what topic, maybe liver or kidney or both, I will try to cover. Okay. So thanks a lot, all of you, for your presence. Uh, any of the question is welcome to me anytime. Like you can ask any question anytime. Okay. Any question before I leave? And this is my number. Anyone can contact me via WhatsApp. You can just drop a message to me. Okay. Thank you very much. So I think the question which Pardeep was trying to ask, that how will you diagnose preoperatively? I don't understand. Clinically, again, I tell you that peripartum cardiomyopathy is a diagnosis of exclusion. There is no test like that. Of course, in that scenario, because in the last trimester, you can do even echo, this one, X-ray, there is no problem. But now with the evidence of using like echo, I even you can see lung ultrasound. you can diagnose the situation, and the treatment will be according to the, like, you are just giving support to the heart, you are giving some vasodilators, and you will try to deliver the baby. Okay, so thanks a lot, all of you. Inshallah, we will try to have another session tomorrow. Bye bye.